Good evening, everyone. Welcome to tonight's webinar. My name is Jay Cranston, and I'm the Marketing Manager at Signifier Medical. We're excited to have you with us as we share the latest updates on therapy access and explore new clinical evidence in sleep health. We're joined by two excellent speakers. First, Dr. Megan Crawford, a reader in psychology at the University of Strathclyde and co-director of the Strathclyde Sleep Center. Dr. Crawford has more than 20 years of experience in the measurement of sleep and non-pharmacological treatments of sleep disorders. She's an internationally recognized expert in insomnia, COMISA, and sleep health. Thank you, Dr. Crawford, for joining.
Thank you very much for having me.
Of course. And we're also fortunate to have our own Signifier Medical's Yasser Zayni, the head of commercial, clinical, and compliance at Signifier Medical Technologies. Yasser has been with the company since 2018 and brings extensive experience across product commercialization, clinical strategy, operations, and regulatory pathways. His leadership has been central in advancing innovative therapies and expanding patient access worldwide. Thank you, Yasser, for joining.
Thank you, Jay, for having me.
Yep, and we also have Cami Osborne on the call as our clinical director of research, and she will be helping us out in the Q&A section portion of this webinar. And then I also want to give a shout out to Alex Jones, who is a data scientist at Swansea University and helped Dr. Crawford bring this real-world evidence to life that she's about to present to us. So thank you, Alex, as well, for your help here. I want to talk through the agenda of how this webinar is going to go. We're going to start with Dr. Crawford as she goes through new real-world evidence. So this will include the impact of eXciteOSA on patient-reported outcomes, eXciteOSA treatment influence on patient-reported outcomes, and then there will be a Q&A segment, so we will take a break to ask questions to Megan specifically. So please use the Q&A function of this webinar to ask your questions, and some of them we may answer in the chat, but some of them we may answer directly in the webinar. And if we don't get to some of your questions, we will get back to you via email if we can't get to everything in this webinar. We'll also go through so once Megan's part is done, we will go to Yasser, who will present the Signifier Medical Company update, talk through a new product innovation, expanded coverage, and we will also have a Q&A segment for him. So again, feel free to ask your questions in the Q&A segment, and we will bring those up. I will moderate at the end. So thank you again, everyone, for joining. We're excited for this webinar, and I'm going to pass it on over to Dr. Crawford.
Thank you very much, Jay. And for anyone who's wondering, the University of Strathclyde is located in Glasgow, Scotland. I won't be treating you with a Scottish accent today. Unfortunately, I'm not Scottish, but hopefully you can bear with me. But I just wanted to reiterate that Alex and I contributed to this analysis, or led this analysis, and the analysis is separate from Signifier. So we were brought on as consultants, just to say that up front in terms of conflicts of interests. So just to bring everyone onto the same page, I just wanted to provide a brief definition of patient-reported outcomes. So patient-reported outcomes, or PROs, PROs are direct reports from patients themselves, either about their health condition, symptoms, treatment effects, or quality of life. And today I'll be focusing on the treatment effects. So just to outline, before I sort of delve into the data, outline some of the available literature that has used eXciteOSA and has included in the clinical trials patient-reported outcomes. So this is data from one of the early trials with eXciteOSA, and this was with 70 patients combined, either simple snorers or those who had mild OSA, and they reported or they collected data on sleepiness and sleep quality before and after the treatment. And what they found was that that there was a significant difference from before the treatment to after the treatment. So before the treatment, sleepiness was in blue here, and then after the treatment here is in orange, and you can see a significant difference between those two ratings here. This is for sleepiness. And then the same for sleep quality. This was measured with the PSCI. So this is before, again, in blue, and after treatment in orange, and there was a significant difference between those two values. And this was followed up with a larger sample of 125 patients. Some of those were snorers, and then some of those had mild OSA as well. And similar results. So this was the Epworth Sleepiness Scale again, and you can see significant results, a significant difference from before to after treatment, and again for sleep quality here. And this is data from one of the first randomized controlled trials comparing the eXciteOSA device with a sham device. And the difference there was the intensity level. So the sham device was a low intensity, and they did treatment for 6 weeks and measured sleepiness at post-treatment, so before and after treatment. And in this, unfortunately, they didn't find any differences in either groups, any significant differences using frequentist approaches. So because the sample size was relatively small, so this was only 40 patients with mild OSA, they conducted sensitivity analysis with something called Bayesian mixed methods. And basically the benefit of Bayesian mixed methods allows you to put a probability to that difference. You can say, with what probability is there a difference between before and after? And so if you look at these values here, you can see with the eXciteOSA arm, the average difference in the sleepiness was 1.8. This is points on the Epworth Sleepiness Scale. And the values here within those brackets, this is what's called the 95% credibility interval. So basically what that means is that there's a 95% chance that the real difference lies somewhere between these two values. And because these two values are both negative, you can say there's a 95% chance that there's a negative difference, an improvement in sleepiness. Now, if you look at the sham numbers, this is a sham device, the change in Epworth is a lot less. And then this credibility interval spans from a negative value to a positive value, and importantly, includes also the value 0. So what that means is that it's a 95% chance that there's either an improvement or a change to the positive, so increase in sleepiness, but also that there's no change. So basically what that means in simple terms is there's a treatment effect for the eXciteOSA device, but no treatment effect for the sham device. That's sort of the simplest terms of explaining Bayesian analysis. So how does this data compare to other daytime neuromuscular electrical stimulation devices, either commercially available or simple electrical stimulation through electrodes? And this seems to be replicating those previous results. So we can see significant improvements in some trials using the Epworth Sleepiness Scale as a patient-reported outcome measure. The same for FOSC, which is a functional outcomes. So it's kind of daytime functioning related to sleep, related to sleepiness. So there's significant differences there with that device. And then also with the PSCI, this is a sleep quality measure again. So overall, it seems like there's an effect of this daytime neuromuscular electrical stimulation. But of course, all of this data is based on clinical trial data. And there are challenges with clinical trials. So people who take part in these trials are usually very motivated to take part. They're often very highly educated. There is a lack of diversity, so often very sort of predominantly white sample. There's an element of social desirability, so participants often respond in the way that they think a researcher would want them to respond. And it's highly controlled. So they often have a number of different inclusion and exclusion criteria. And so you end up with a sample that doesn't actually represent who you see in the clinic. And so if you want to understand, well, how is my patient actually going to be responding to this treatment, you don't really know because your patient isn't comparable to what you see as a participant in these clinical trials. And so there's a real need for this real world evidence. There we go. So this is what we did here in this data analysis. So we took the real world data, so real patients who were using the eXciteOSA device and had started treatment, and as part of that completed a baseline questionnaire, and then completed 42 therapy sessions, and then filled out a post-treatment questionnaire, and then subsequent questionnaires in the maintenance phase after those initial 42 therapy sessions. And there are certain patient-reported outcomes that were collected as part of the app. There was a sleep disturbance and the sleep-related impairment, and this was measured with the PROMIS scale versions of these PROMIS scales. And the PROMIS is a really interesting scale or measurement because it allows you to calculate standardized scores. So you can say if someone has a score of 50, that's within the normal limits, and that will be comparable to other scales of different types of measures for different conditions. And then if they score between 55 and 60, they're in mild, 60 to 70 moderate, and then 70 to 80 would be severe. Higher numbers indicate worse sleep, and lower numbers indicate better sleep. Depression was measured with a PHQ-8, which is the PHQ-9 without the suicidality item. And this, similarly to the PROMIS, has certain cutoffs. So the cutoff 10 is usually used to indicate depression, and there are subcategories here. And it measures sort of aspects of depression. Then there was the FOSC, which measures functioning related to sleep. So this covers items such as difficulty concentrating or difficulty remembering things, all related to being sleepy or tired. And a common cutoff that's used in the literature here is 17.9. And then lastly, the work impairment was measured with the WPAI, and this measures aspects such as absenteeism and presenteeism. And then there were also treatment variables that we could extract from the data. So we had a measure of adherence, and this was operationalized as the length of time it took for patients to complete 42 sessions. So if someone was using the device every day, then they would take 42 days to finish those 42 sessions, but they could have skipped a couple of days and then taken longer. And so the length of time, so closer to the 42 sessions, would be better adherence, and if it's longer, then that would be poorer adherence. Treatment intensity was measured through the intensity settings on the app. And then we also were able to capture that the app's able to capture intensity variance, so the kind of variability from day to day or session to session in the treatment intensity. And this was all done under the ethical approval from the University of Strathclyde Ethics Committee. So once we were able to extract all this data, we looked at those individuals who had at least 2 questionnaires, and that gave us a sample of 736 patients, and those were those people who had provided data up until November 2024. Then we decided to look at only those individuals who had a post-treatment questionnaire within 1 month of completing their 42 sessions, because we believe that would be a more true representation of a post-treatment assessment of their symptoms. And that reduced the sample down to 472 individuals, which is still a very large sample. We wanted to ask a number of different questions, or answer a number of different questions. The first one is there simply a difference from their pre-questionnaire to their post-questionnaires? And we used a Bayesian hierarchical model, and I'll explain what that means in a minute. And within that model, we controlled for adherence, treatment intensity, and intensity variance. We are also interested in the dose-response relationship. So there's a relationship between treatment adherence, treatment intensity, so the dose of treatment, and patient-reported outcomes. And then we were also interested in understanding how many individuals fall below a certain cutoff at post-treatment. And in order to do that, we use something called posterior predictive simulation. And again, I'll explain what that means in a minute. So the demographics of this final sample of these 472 individuals, they were 56 years old. They were predominantly male, so 41% female, primarily located in the United States, predominantly white, and had a BMI of 29.1. So looking at the data for the first question, so just as a reminder, what we wanted to know here is what's the difference between the pre-questionnaire and the post-questionnaire. So are their symptoms improving after those 42 sessions, controlling for adherence, intensity, and intensity variability? So this looks like a very busy slide, but we'll walk you through this step by step. Basically, what each sort of quadrant shows you, or sort of square, shows you each patient-reported outcome. So we have here sleep disturbance. Let's focus on this for now. So sleep disturbance, that PROMIS scale. So an item would be, for example, from this scale, and the past 7 days I had a problem with my sleep. And what we looked at was the pre-rating and compared that to the post-rating. So the pre-rating is in red and the post-rating is in blue. And what we're looking at here is an overlap in these black bars. And you can see here there's no overlap in these black bars. So what we can see is that there is a treatment effect. And the interesting thing about Bayesian analysis is we can again put this probability on this. So we can say there's a 100% chance that there will be an improvement after 42 sessions of the eXciteOSA device in your sleep disturbance. The same was the case for sleep-related impairment, so how they're feeling during the day, so like having a hard time getting things done because you're sleepy. Again, no overlap in these bars, and there's a 100% chance that there's a difference at post-treatment. This is the same for depression. So an example item is how feeling bothered by feeling down, depressed, or hopeless. And again, no overlap in these bars between the pre and the post. And again, 100% chance that there's a difference between these scores. The daytime functioning, so this was measured with the FOSC. So an example item of this was having difficulty concentrating on the things you do because you're sleepy or tired. And here you can see that there is an overlap with these bars. So if you kind of merge them together, you would see that they would overlap. And so there's no treatment effect here for the FOSC. And if you look at that probability here, you can see there's a 38.7% chance that there will be a difference. So a lot lower than those other measures. There was an overlap here with absenteeism, so no treatment effect. So this is missing work because of health problems. And there's a 97.2% chance there's a difference. Then for presenteeism, there was no overlap. So there is a treatment effect and a 99% chance that there is a difference. How this health problem affected their abilities to do regular activities. There was no overlap, so there is a treatment effect. And then this was the overall work productivity scale. And you can see here no overlap. And there's a 99% chance that there is a difference. So basically all this is saying is for the majority of these patient-reported outcomes, there's a change at post-treatment, and the probability that there's going to be a change is near 100% in almost every case. So really encouraging. Okay, question 2. We wanted to know if there was a dose-response relationship between the patient-reported outcomes and these treatment variables. And our hypothesis is, well, if you use the treatment more, then you have a better response. So if you take shorter time to finish those 42 sessions, you're going to have a better response. If you have a higher intensity setting, you'll have a better response. if you have lower variability in your intensity settings, then you'll have a better response. But unfortunately, that wasn't the case. So we didn't find a dose-response relationship. But I would like to emphasize that most of these patients were very adherent. So they finished these 42 sessions within, I think, 50 to 60 days. So very, very adherent. So basically what you're doing here is instead of comparing poor adherence to good adherence, you're actually comparing good adherence to excellent adherence. So there's probably no surprise that there wasn't a dose-response relationship there. Okay, and then the last question is how many patients were who were above the cutoff before treatment were below the cutoff after treatment. And what you can do in simple terms is you could look at the data. So you could say, okay, well, I have 475 patients, or I have, let's say, 400 patients who are above the cutoff. How many of those are going to be below the cutoff at post-treatment? You could just say those in simple terms. But what you can actually do with Bayesian analysis and with this posterior predictive simulation is you can actually use the data from those previous models, and you can ask the model to simulate a new data set and basically say, well, if we collected all this data again, what would the data look like? How many of these individuals who are over a certain cutoff would actually finish off below a cutoff? And what's the probability that they would do that? So this simulation allows you again to put this probability on things. And this is much more intuitive. So here you can see this is simulated data. So this isn't real patients, this is just simulated. So you can, but it's based on the previous data. So what you can see here is that if you imagined a patient between, I think it says 15 and 17 on the FASC, how likely is it that they would be, now this is a FASC is reverse scored, so how likely is it they would be above the cutoff? This dashed line is the cutoff of 17.9, and the probability of that is 26%. So there's 26% chance that if they're in the abnormal range, that they would be in the normal range. So I shouldn't really use the word normal, but in the non-dysfunctional range. And that probability is 26%. So what about depression? So this is the lower score is an improvement. So here we're looking at, you're saying, okay, if we imagine an individual who scores, say, 11 on the PHQ-8 before they start treatment, what's the probability that they would be below the cutoff of 10, so have no depression at the end of treatment? And that probability is 91%, so pretty high. What about sleep disturbance? So if you again imagined an individual or a patient who had a score of 60, say, what's the probability that they would be below that cutoff of 55, so within the normal range, the non-sleep disordered range after treatment? And that probability is 86%. And for sleep-related impairment, that's 87%. So what this data shows is that the probability that individuals will be below a cutoff if they're in this range above the cutoff is pretty high. So what you could say to your patient is, well, if your patient has a sleep disturbance pre-treatment score of 60, it's an 86% chance that they'll be in the normal range after 42 sessions of eXciteOSA, which I think is pretty powerful to say. So that's enough Bayesian analysis, I think, for today. So in terms of a summary, there are considerable treatment effects for these patient-reported outcomes at post-treatment in this large sample of real-world eXciteOSA users. The strengths of this study are the large sample, the fact that we used real patients, and we used sophisticated Bayesian analysis. And Bayesian analysis, hopefully I was able to show you that it offers a more intuitive interpretation of what's actually happening. The limitations are that we didn't have a control group, so we can't say whether these treatment changes are related to other effects or regression to the mean. And then, as I mentioned already, there's limited variability in adherence. So we don't really know what happens if you're not adherent to the device and not using the device. And that would be really interesting to see. So that would be something we could probably look at in a larger randomized controlled trial. It'd be good to have look at longer follow-up data, which is available, which we can do. And then also quite interesting would be maybe some cost effectiveness analysis to kind of match these patient-reported outcomes to the cost of the device to have a sort of cost-benefit analysis. And that's all from me.
Great. Thank you, Dr. Crawford. Yeah, it's really exciting to see all of this data come to life and show the improvements that eXciteOSA can have on people's quality of life and sleep habits. So we appreciate all the work you've put into this. So thank you for presenting it. And yeah, it looks like we've got some questions. So I'm going to open it to Yasser and you, Dr. Crawford, or whoever wants to answer the question. One we have came in, it says, what kind of long-term compliance and patient satisfaction rate are you seeing compared to traditional CPAP therapy?
So that, I mean, I can't answer that with the data that we have here because that's not something that we did. And I think just one thing to say is a challenge, of course, is that if you're looking at CPAP trials, those would be samples of individuals who have mild or moderate to severe OSA rather than mild OSA and simple snorers like this population here. So it's probably quite difficult to compare because they aren't comparable samples, if you understand that, if that makes sense.
Well, thank you for that. If I may add to that, so I do agree it is difficult to compare CPAP compliance to eXciteOSA compliance because one is nighttime usage versus daytime usage, essentially. So the usage of CPAP is usually not measured across how many nights of the week or how many nights in a row that you use it, but it's the number of hours during the night you actually use CPAP. Where in the case of eXciteOSA, it's 20 minutes and it's measured usage per day. But ultimately, the average compliance we have seen to date with eXciteOSA ranges between 80 to 83% of adherence or compliance to daily therapy within that first phase of 6 to 8 weeks.
Great, thank you. Okay, so question, what does this mean for the patient that a physician sees in their clinic? So this information that you shared, Dr. Crawford, what does it mean for the patients coming in?
Yeah, that's a very good question. So this is the benefit of these Bayesian analysis, is because you can put that probability. So you can, I think a probability is a lot more easy for a patient to understand rather than sort of statistics where you say, well, this is a significant difference. And what does that actually mean? So you can say, look, if you have a sleep disturbance before you start treatment, there's an 86% chance that you're going to not have any sleep disturbance when you finish your 42 sessions. So that is a lot more palatable and a lot more understanding for people kind of in their day-to-day lives are kind of working probabilities already anyway. So an 86% chance, well, that's pretty high, right? That's a really high chance that I will see an improvement in my sleep so that I don't have a sleep disturbance anymore at post-treatment.
Great, yeah, no, thank you. How does the treatment for snoring OSA have an impact on depression? What are the mechanisms?
Yes, well, I should say there's one caveat, and there's something probably that we need to look at, is that the PHQ-8 item also has a sleep item in there, so which we probably should do some sensitivity analysis to take that out, to look at just the depression items to make sure that the impact is also on depression. But sleep and depression are very tightly linked, and we've all had that. We've all had a bad night where you feel groggy and irritable the next day. And there's a lot of data to show that if we have disruption in our sleep, then we're more likely to develop a mood disorder later on. It also predicts relapse from depression treatment if you don't treat, for example, insomnia or general sleep disturbance. So there are lots of different theories. I think one theory that I find really exciting is a REM instability theory, which if you know about the importance of REM in emotion regulation. So if you have a disruption in your REM sleep, then that emotion regulation is impaired, and that might be a pathway to develop depression or other mood disorders. So if you have, if you're a snorer or you have OSA, you have a disruption in your REM sleep stage or kind of REM instability, and that will then disrupt that emotion regulation processing that can then lead to the kind of mood development. So hopefully that explains that link.
Yeah.
Potential mechanism.
Yeah, no, it's interesting, and also to think about the different research that can still be done and looking into the different aspects of sleep and how it affects it. So I guess one of my questions would be, what are the next steps in terms of research with this device that you see?
Should I talk personally as a researcher now, or I mean, I think it would be my background is insomnia, and so I think one thing that would be really interesting to do is to understand how this might be helpful for people who have insomnia and comorbid sleep apnea, because CPAP is really a treatment that doesn't work very well in that population, and they really struggle. There's one of my qualitative studies, there was a really interesting, it's a sort of tongue-in-cheek comment, but the person said, well, the CPAP doesn't really help me when I'm awake. So they have insomnia, they're awake, the CPAP doesn't work, right? So a daytime therapy would be really helpful, I think. So that would be, I think that would be really interesting to look at.
Yeah, now to Yasser. Okay, what are we doing? What's the research coming?
Well, obviously, we were very successful in the sham RCT that we did, and obviously we are looking to expand on that and do a larger sham RCT to measure the effects of eXciteOSA on a larger patient population. And of course, the question always comes up around what changes are we introducing into the physiology of the upper airway and the junior glossus, and how do we measure it and quantify that change essentially. And of course, one of the questions that were raised just now for Megan, Dr. Crawford, with respect to what does this mean clinically? Essentially, can we create predictors of success with this device, eXciteOSA? Is it through PROs that we will initiate with the patient to understand will they have a high probability of success with therapy, and then from an objective measure, can we have some predictors of success? So these are all areas we are wanting to research and investigate to be able to better inform the benefits of this intervention and of course further innovation in NMES within obstructive sleep apnea.
Great, something to look forward to. I have one more question for Dr. Crawford, and then after that, she's going to leave, and we're going to have Yasser come on and present some company updates and product updates. So are there any plans to recreate the study with the inclusion of AHI scores?
That's a good question, and I'll have to refer to Yasser to that, because I'm not 100% sure about accessibility of that information.
The hope is to be able to always combine objective with subjective measures, right? Because ultimately, objective measures is the gold standard for assessing effectiveness, most definitely. But of course, you can never discount how the patient is feeling, what the patient is telling you they're doing, and what the outcomes associated with patient feedback, essentially. And AHI is the gold standard or the golden measure for obstructive sleep apnea outcomes. So yes, we've done studies historically measuring AHI and assessing patient-reported outcomes, and we are expecting to continue doing so. And of course, to be able to tap into the real-world evidence that exists with our prescribing physicians and clinics to be able to combine the two from the real world of existing existing patients and from the patient population of eXciteOSA. It's something that we would look to do as well to make the analysis more impactful and more meaningful to our clinical and prescribing physicians, essentially, so that they are fully they fully understand the impact of the intervention of eXciteOSA. So yes, we would be wanting to introduce AHI and other objective measures with this patient-reported outcomes as a package of real-world evidence for eXciteOSA.
All right, thank you. Well, thank you, Dr. Crawford, again for joining us. Exciting data that you shared, and I'm sure the people really enjoyed seeing some new clinical evidence to show the world. So thank you again. We appreciate all your help with the study and your help with this webinar. And don't leave, everyone. We still got Yasser coming on next. But thank you. Have a good night.
Thanks very much for having me.
Thank
Bye,
you.
everyone.
Thank you so much.
All right, Yasser, if you want to pull up the presentation. Now we're going to hear from Yasser about some company updates, some product innovation, and where we are with reimbursement today.
Perfect. Thank you so much, Jay. Of course, I want to thank Dr. Crawford again for the analysis, and Alex Jones as well for the analysis they did for the real-world evidence. Very impactful and very meaningful. And we are hoping to continue to monitor the effectiveness of eXciteOSA in the real world to assess what patients are reporting with the use of eXciteOSA. And also, before I get going into my segment, I want to thank Jay for putting this all together for us. Always very meticulously thought out and very meticulously put together. So thank you so much, Jay, for that. So eXciteOSA, as this slide would say, is back and hopefully better. What we wanted to do is to share where we stand as a company and the progress we've made after a challenging year, and how reimbursement developments are opening up new opportunities for eXciteOSA and our partners. Last year, we experienced significant fulfillment delays. These stemmed from transitions in our manufacturing footprint and global logistics challenges. Naturally, this disruption affected our patients, our DME partners, and our broader network. We acknowledge that this may have had an impact, and it's been our focus to put things right and to put measures in place to ensure resilience in our manufacturing and supply chain and prevent the repeat of the challenges we've had over the past year. So what we've done, we've diversified our manufacturing base with production occurring in both China and, more importantly, a manufacturing hub located in North America. This reduces dependency on a single geography and strengthens our resilience. We have reinforced our quality systems, ensuring reliability at every step. Our fulfillment and logistics process have been streamlined so that we can deliver consistently and transparently. This was about not just solving our short-term problems, but future-proofing our supply chain. What we've also done is brought about through enhancing access and usability of the eXciteOSA is a remote control option. This hardware innovation will hopefully provide a consistent, effective treatment experience for those specific users that want or can't use a smartphone application or don't have access to a smartphone application. This is also a direct intervention to or supporting claims for CMS through the HCPCS code product definition that we've been provided by CMS. So one of the more exciting areas of progress that we have had significant activity in is we've been successful in achieving the HCPCS codes E0490, which is the remote enabled starter kit, and the E0491 for mouthpiece replacements. So these are recognized under a capped rental DME benefit, and we have had successful claims for Medicare being processed following more or less a similar pathway currently used for CPAP claims, which provides a broad precedent that gives confidence in the reimbursement landscape. We've also achieved Medicaid coverage policies through active engagement in states in Georgia and in South Carolina, with hopefully expansion underway in additional states and hopefully coverage policies being approved in further states. This reimbursement progress means physicians and patients now see clearer access pathways, which is critical for adoption and scale. Our commitment. We know we must rebuild trust with our partners, with our providers, and with our patients. That trust will come through consistency, consistent supply, consistent quality, and consistent support. We remain committed to supporting every partner and every patient, as we believe strongly that we are all stronger together. eXciteOSA is not just back on firmer footing with reimbursement support and supply reliability that allows us to scale responsibly. So once again, from the deepest, from our hearts and from everybody at Signifier, thank you all for your partnership and your patience over the past year. We're excited for this next chapter, and we look forward to working closely with you as we bring sleep health to more patients. Thank you.
Thank you, Yasser. Very well said. Yeah, we're excited to be back and help physicians, patients, DMEs, all with eXciteOSA and get more people the help they need for better sleep. So thank you. We do have some questions that have come through. What kind of patient responds best to eXciteOSA? Are there specific characteristics that make them ideal candidates?
Great question. Of course, the intervention with eXciteOSA is neuromuscular electrostimulation of the genioglossus to improve the endurance of the tongue and to keep the tongue in its position for longer during sleep. So the major root cause for obstructive sleep apnea is the tongue collapsing into the upper airway. So if there are other contributing factors, or there are other causes for obstructive sleep apnea, such as enlarged tonsils, for example, then stimulating the genioglossus to improve his endurance, it's not really going to be that effective. So having an understanding of what the underlying cause is for the collapse of the upper airway would be a good indicator towards the probability of success with eXciteOSA.
Great, thank you. How does the new remote control option work, and is it required for Medicare coverage?
Great question. Yes, the HCPCS code that has a DME benefit associated with it, the E0490, the definition for that HCPCS code requires a hardware remote to be used for the claim. So the hardware remote for the eXciteOSA for the SKU 18010 will need to be used for claiming under Medicare for eXciteOSA. The remote is Bluetooth paired, or utilizes Bluetooth technology to pair with the control unit, and the data that is stored on the remote control will be used for adherence reporting, and it will give the full flexibility for the patient to increase and decrease intensity of the therapy as they progress with their eXciteOSA journey.
Great. Is there a national Medicare DME provider to whom they can send scripts to for eXciteOSA?
Yes, there is. We've got a couple of partners, trusted partners, that are using eXciteOSA or distributing eXciteOSA. Predominantly, we've got a trusted partner in Spectrum Sleep Solutions, who are taking on Medicare claims and supporting patients through that process. And we are hopefully, with the release of the new SKU, we're expecting a scaling of those operations in due course.
Okay, thank you. What commercial insurers pay for eXciteOSA?
At the moment, there hasn't been as much traction as we would like on that front. Reimbursement is a journey, and the first milestone, or the first stepping stone on that journey, is getting HCPCS codes, which we have for the eXciteOSA. And we are on this journey, and we are making progress on that journey. We have coverage policies in Georgia and South Carolina, which again provide a good platform for us to engage further with other states in Medicaid, and we are on a journey towards an LCD with Medicare. And as those policies start to become live and become available, then of course we are expecting more and more commercial payers to come on board and have policies for eXciteOSA. So we are on this journey. We are making significant progress, and we are hoping and expecting to be able to increase the covered patient population in time.
Okay, thank you. Does the hardware remote allow the device to be used when there is no cell or Wi-Fi service for a mobile phone?
Yes, I know that has been a challenge for a portion of our patient population. When they go camping, they are very dedicated to continue with their therapy, but with no cellular service, it makes it a bit challenging to have connectivity for the smartphone to enable the app to operate and to connect to the control unit. So yes, the hardware remote can work offline, and it doesn't require any connectivity to be able to connect to the control unit and to be able to run therapy.
Okay, and then there's a question, only in Georgia and South Carolina, Medicare and Medicaid pays. So the Medicaid I know is Georgia and South Carolina.
Correct.
Correct.
Correct. Yeah. And Medicare is national. Medicare claims are being successfully processed nationally. But at the moment, the two states that are covering under Medicaid are Georgia and South Carolina.
All right, well, that wraps up the questions and wraps up our webinar. Is there anything else you want to say, Yasser?
No, I think we've covered it all during the course of the past 50 odd minutes. We are on this journey with our providers, with our partners to expand the access to eXciteOSA. We appreciate all the feedback we have received in time. We're always appreciative of the support, and we are hard at work in trying to continue to best support our partners and, more importantly, our patients towards successful outcomes. Essentially, we are here to serve and to support. So we're always here to listen and try to be better at doing the right thing to our patients. So thank you all for your continued support with us on this journey.
Great. Yeah, thank you, everyone, and thank you, Yasser, for sharing all of the insights tonight. Hopefully, the session has helped highlight the growing evidence based around eXciteOSA and the expanded coverage and the introduction of the remote control. We will have a recording of this webinar, so you will have the ability to watch this again. And on behalf of the team, I just want to thank you all again for your time and engagement, and we look forward to continuing the conversation and working forward together. So thank you. Have a good night, everyone.
Thank you.